Hi, everyone. Thank you for joining us today for our webinar. We are just going to give it a few minutes and let others join, and then we will begin shortly. All right. Hi, everyone. Thank you so much for joining us today for our webinar with Paula Pickard from Horizon Health Network. Today, we are going to be hearing from our speaker or speak on the Coordinated Aging in Place Services CAPS project with the Integrated Primary Health Care. Oh, not again. My screen is refusing to move forward. Okay. We did this the last time. All right. So our aim with the policy round webinars is to share research from different speakers on what their findings are and what policy implications the research may have for aging adults. So today we have Paula Pickard, like I indicated, and she will speak for roughly 20 minutes, and thereafter she will have a 10-minute Q&A to answer all your questions. So feel free to pop them into the Q&A as we go, and then she will answer to those at the end. You can take it away, Paula. I'll just stop my share.
Oops. Are you seeing my screen, Norma?
Not yet.
Okay, just a second.
Yeah, I have it now.
I'm just trying to bring it up from the beginning. Is that the full screen? Okay.
All right, now you have to swap display like you did the last time. From there, yeah. Okay, there we go.
Thank you very much, Norma. And so thank you, everyone, for this opportunity. And thank you to AgeWell for this opportunity. As Norma mentioned, I'm Regional Manager for Chronic Disease with Horizon Health Network in New Brunswick, and one of the co-investigators for this study. And our study is titled CAPS, Coordinated Aging in Place Services with Integrated Primary Health Care, a mixed method study. And I first would like to just acknowledge our funders for our study, Public Health Agency of Canada and New Brunswick Healthy Seniors Pilot Project. So some key issues that we addressed with our study, one being the high incidence of chronic illness with New Brunswick older adults. About 87% of our older adults in New Brunswick have at least one chronic condition, and 43% have at least 3 or more chronic conditions. But interestingly enough, only about 36% of our older adults feel very confident in managing their chronic conditions, which could lead to exacerbations, health decline, and hospital admissions. And we are seeing an increasing incidence of our older adults admitted to hospital. Another issue that we want to address is frailty, and just to help to reduce that risk of frailty and raise the awareness of the risk factors for frailty and frailty interventions in our clinicians in primary health care. And we also wanted to enhance our team-based primary healthcare services for older adults and strengthen these services in primary healthcare to help our older adults age safely and independently in the community. So our research goal was to pilot an innovative care pathway. We wanted to identify the impact of a nurse-led, multidisciplinary, frailty and chronic illness case management service within primary health care for at-risk community older adults and their caregivers. So our innovation for this was really utilizing the multidisciplinary team to the full scope of practice within primary health care, and also enhancing our integration of a team approach in primary health care. And then for another element of innovation, we wanted to engage the caregivers in this study as well, because typically the caregivers or family members of older adults typically do not attend the medical appointments with older adults at the health centers. So we wanted to invite the caregivers to attend those medical appointments and be part of the care planning for older adults. So our objectives and impacts for our study, we were hoping to have our older adults more supported in the community, such as improving confidence in managing their chronic conditions, improving their awareness and access of community resources, decreasing frailty risk factors and the risk for falls of our older adults, and improving the quality of life. We wanted to have our caregivers more supported in the community and reducing their burden of care as a caregiver and improving their awareness and access to community resources. And then finally, we were hoping to have some healthcare team improvements, specifically improving the use of staffing resources for our health team, improving our team collaboration, and improving system processes. So what does CAPS offer? Our CAPS service offered these 5 elements, and at the very top, you'll see frailty screening. So we, for our frailty screening, our registered nurse conducted the comprehensive frailty assessments for our CAPS patients, and we developed an assessment tool based on current evidence-based resources and literature for frailty. And we also integrated the geriatric 5Ms model into our frailty assessments. Geriatric 5M framework identifies 5 key elements that should be addressed, which will produce positive outcomes in older adults. So we integrated clinical assessments that address each of these 5Ms into our frailty screening tool. And the 5Ms being mobility, mind, medication, multi-complexity, which we target chronic illness and determinants of health, and matters most. Our CAPS team asked the older adult, what matters most to you? So that was another element that we targeted. So the frailty screening, having the registered nurse complete the comprehensive frailty screening enabled the nurse to work to their full scope of practice and do some clinical assessments that typically would have been done by the primary provider or other clinicians. So from the frailty screening, then the CAPS team developed patient-centered goals, and this was done in collaboration with the patient and the family member, utilizing all of the assessments as above. And the CAPS team consisted of the registered nurse, the occupational therapist, and the social worker. So all of our CAPS patients, they all had an appointment with the registered nurse who conducted the frailty screening. And then each of the patients had at least one appointment with the social worker or the occupational therapist for further assessments. And then from that, each of our CAPS patients received case management. And this was an ongoing regular appointment with one of the CAPS team. So the appointments had to be at least every month with the CAPS team, and if not more frequently, for some of our patients, it was a bit more frequent, but at least once a month, they had an appointment with the CAPS team for a duration of 6 months. So they had this ongoing case management and self-management support. the registered nurse acted as the case manager. So our registered nurse was the primary clinician that followed most of the CAPS patients. But if some of our CAPS patients had more needs that were related to function or social needs, then the patient would have the social worker or occupational therapist as their case manager. But majority of our patients had the registered nurse act as the case manager, provide that regular follow-up. And case management, this regular ongoing follow-up with patients, our older adult patients, is something that we typically don't do at our health centers. So we wanted to see the effects of this. Then next, we offered an element of outreach in our study. And so what this looked like, each of our CAPS patients received a home safety assessment conducted by the occupational therapist. And so the occupational therapist went to their home, completed the assessment, and implemented safety interventions. Another element of outreach was with our follow-up appointments. We had asked the patient how they wanted their follow-up appointments, if they wanted them in person at the health center or by telephone, or for those patients that had transportation barriers, that we offered that we could do a home visit to do the follow-up appointment. And so these elements of outreach, going to a home to complete appointments, is something that our health centers typically don't do. So we wanted to evaluate that in the study. And then finally, we offered consults and connections. So our CAPS team members became navigators for health and social services and resources. They provided internal and external referrals to other healthcare professionals. They acted as a navigation support, providing the patient and the family member community resources. And also the CAPS team met every month with the primary provider to review the care needs and interventions with the provider. So our research method, our study was a concurrent nested mixed methods design. It was predominantly a qualitative study with supportive quantitative descriptive data. And our research questions were, what are the experiences of the patients, family caregivers, and healthcare providers who participated in the CAPS intervention? And how did this experience compare to their previous primary care experiences? So for our method, our participants, we did use 2 of our health centers at Horizon Health Network that are situated in a rural setting. And we had 3 types of participants. So one set of participants were the older adults, and we onboarded 21 older adults who were our patients. And these older adults were from the community, 65 years and older, and they were identified by the primary provider from the provider's rostered patient list. And they were older adults that met the eligibility criteria for CAPS. And so for the CAPS service, the patient had to be 65 years and older with one of the following. So they had to have one chronic condition that was not controlled, meaning that they were having frequent appointments to the provider or the emergency room, or they had 3 or more chronic conditions, or they had a clinical frailty scale score between 3 and 6. A score of 3 means they're managing well, but not regularly active, up to a score of 6, meaning moderately frail. We onboarded 10 caregivers who were family members or informal caregivers of the consented patient or older adult. And we onboarded 8 healthcare providers who were the multidisciplinary team from the 2 involved health centers, either physician, nurse practitioner, registered nurse, social worker, or occupational therapist. So the method for our data collection, we did collect demographic data from the older adult and the caregiver using a questionnaire at the first CAPS appointment. And also with the older adult or patients, we collected descriptive quantitative clinical data. And this was done at pre and post CAPS intervention. And we also collected some healthcare utilization data for that quantitative data. And then for our qualitative data, we utilized a semi-structured interview conducted at the end of the CAPS intervention and did this for all of our participants. And so our findings for patient demographics, for our older adult patients, we had 16 that completed the study. There were 5 that withdrew from the study for various reasons. One of our older adults, during the 6-month CAPS intervention, one of the older adults became medically unwell and had to withdraw. And the 4 remaining older adults did complete the CAPS intervention, but 2 had increasing cognitive impairment and could not complete the qualitative interview, and 2 of the older adults declined the qualitative interview. You'll see that we had 9 caregivers complete the study and all 8 of the onboarded healthcare providers completed. The average age of the older adults for our service was 76, and the average age for the caregivers was 72. And 81% of the older adults were female, and about equally split for the caregivers being male and female, with just a slight majority of the caregivers being male. And then you'll see the education level there. We captured some data. Just wanted to share with you some interesting descriptive quantitative data that we observed in our findings. So for our clinical assessments, some of our clinical assessments we conducted pre and post CAPS intervention, and our clinical assessments for depression and medication adherence showed better results at the end of the CAPS intervention. And for self-rated health, we had asked our CAPS patients pre and post to rate their health, and more patients rated their health as good or excellent at the end of the intervention. And then for referrals and connections, most of the referrals the CAPS team provided to the patients were to community organizations and services, such as non-governmental organizations, municipality services, and Department of Social Development services. And so the findings for our qualitative data, our top qualitative themes for our older adult patients were CAPS team gave me lots of information and places to get help. The CAPS program was very good and helpful. And the older adults found care was better with the CAPS team compared to previous primary care experiences. And one quote from a patient was, "I felt more comfortable talking to the CAPS team than I did talking to my doctor." And this might have been related due to the fact that with the case management, those frequent ongoing appointments, the patient developed that trusting relationship with the CAPS team, and they were able to have those conversations with the CAPS team a bit more. They felt more comfortable. Some top qualitative themes for the caregiver were CAPS was excellent, CAPS provided helpful information, and the caregivers found care was better with the CAPS team compared to their previous primary care experiences. And a quote from the caregiver was, "Just helping her, the patient, get some mobility and balance. She's more willing to go grocery shopping now." And the top qualitative themes for the healthcare provider, the providers that were not part of the CAPS team, patients had fantastic care with CAPS. They felt supported by the CAPS team, and they would like CAPS program to be implemented. And quotes from the providers were, "I think there were many things that probably would have flown under the radar if it wasn't for the CAPS team picking it up." And another quote, "I was able to see many more patients. It was a much more better use for everybody's time, I think, and better care for the patient." And then the top qualitative themes for the healthcare providers who were part of the CAPS team, we felt supported together as a team. Being in a rural area makes access to services difficult. And a quote that supports that was, "A lot of chronic pain needs were identified, and a lot of the clients in a rural area didn't have the ability to travel to see a physiotherapist." So the CAPS team did see that the citizens living in a rural area had limited access to services. And feeling supported as a team, one element of our our CAPS service, we strive to integrate processes for the CAPS team to have better communication with each other. So part of the process for our CAPS team, they met weekly to review patient care plans and complex patients. The CAPS team met with the providers monthly to review patient cases and care needs. And and then also we developed we trialed a multidisciplinary care plan, a process where all of the CAPS team members could document the patient's care needs in one place. With our existing documentation at these health centers, one health center was electronic documentation and one health center was paper based documentation. So we trialed an electronic documentation process where all the CAPS teams documented in one central location so that they could all see what interventions that they put in place and what the plans were. So this was really helpful for communication amongst the team. So policy implications from our study: multidisciplinary case management service for older adults within primary health care provides positive experiences and outcomes. Utilizing the healthcare team to their full scope of practice can be an effective use of resources. Regular, ongoing patient follow-up can help to establish trusting therapeutic patient relationships and facilitate effective self-management support for older adults. And then finally, implementing evidence-based clinical practices can assist in achieving positive patient outcomes.
Thank you, Paula. I think you are ready for the questions now. Can you hear me?
Yes, I can.
All right, all right. So if you want to go ahead, we have two so far in the Q&A. I don't know if you can see it.
I see. For one question is there any assessment on oral health? And we did part of our frailty assessment. We integrated we didn't specifically address oral health per se. We actually integrated nutrition assessment. So we did utilize the nutritional assessment questionnaire and just to evaluate nutrition. But that was a question that did come up as we go through our sustainability of this project. So we're actually entering phase 2 of CAPS. We received a little bit of funding to sustain this project at one of the health centers, and that had been feedback to evaluate oral health. So thank you for that. So as you can appreciate, our comprehensive frailty assessment got quite lengthy because we were trying to integrate all the best practices for evaluating frailty and geriatric risk. And so in itself, it took about an hour to complete the frailty assessment because one element we were assessing was medication. So the process we used for medication review was the best possible medication history process, which is from Accreditation Canada. So for some patients, doing the medication review took about 30 minutes of our time. So unfortunately, we did not do the oral assessment. Another question, maybe this is still coming in the presentation, was a cost analysis done? Unfortunately, we did not do a cost analysis as part of our study. That we would love to be able to have funding to do that impact analysis for costs, but that was not done in this study. Were you able to measure changes in healthcare utilization? Because our study period was just a short duration, it initially was only for a year, that we were not able to evaluate the impact to healthcare utilization and to evaluate that access to emergency department or hospital admission. So that would be, again, another phase that if we had funding for that, we would love to evaluate that. Can we incorporate long-term care homes into the process? Help navigate clients to a care appropriate home when they aren't satisfied? Now, I'm not sure what the question is asking about incorporating long-term care homes in the process, but for our CAPS team, we actually worked closely with Department of Social Development, and they govern our long-term care process. So our CAPS team members assisted our patients in accessing the long-term care process if they needed homemakers, for example, or if they needed that additional support. Our CAPS team actually helped the patients navigate that long-term care process. I'm not sure if I answered that question accurately, but if they can maybe ask another question. Could you please expand on your sustainability plan beyond the grant funding? So our sustainability plan for our CAPS programs, we piloted at 2 of our health centers. And right now we received a small bit of funding from Healthcare Excellence Canada to be part of their Strengthening Primary Care program, which is from November 2023 to September 2024. And this phase 2 of the project is just to scale up and sustain the CAPS service at one of our health centers by empowering other clinicians to be part of the CAPS team. So we're going to start there and then do further evaluation of our processes with the goal then of scaling up this CAPS program to our other health centers in Horizon Health Network. There'll be health centers that would have the capacity to do that. Some of our health centers in Horizon don't have the full scope of the multidisciplinary team. So having the multidisciplinary team available at the health centers will enable those health centers to onboard the CAPS program. From experience of the 16 participants who completed the study, half would have chronic oral inflammation and 1 in 3 would have active dental caries. Poor oral health is bidirectional with frailty, diabetes, confusion, and mood disorder, so it's vital to deliver oral health care to deliver better outcomes. New models are available for us. Are you interested in the next phase in learning more about this? And yes, I am. I certainly am interested in that, and I can put my email in the chat maybe, just so that if anyone wants to contact me.
I've just added it, and they can pick it up from there if they want to contact you. So
perfect. Yes, thank you very much, because I know that was some feedback.
All right, so we are almost at our time, but thank you so much for this presentation. And it does sound like it is very meaningful and it holds promise for helping older adults to age well in place and to deal with whatever conditions they are confronting. And I like that caregivers were also included, so that was a meaningful, part of the process for CAPS. But what I wanted to find out, and I think maybe you may have answered it when I was busy typing in the chat, but was what are the, like with CAPS, it seemed like there is a lot of stuff that is involved. And we know that right now in healthcare, there are issues with recruitment of all occupational therapists, registered nurses, social workers. So how would that look for CAPS?
That's a good question. And actually, at one point that I didn't highlight is we got creative with using virtual care. So for example, so if some of our health centers don't have those healthcare providers available at them, that we would send a referral. But we also had an example of using virtual care. So the patient had to have an appointment with a speech language therapist, which is at a neighboring hospital, and the patient did not have funds to travel to that hospital. So we used a staff-assisted virtual care appointment where the CAPS team member sat at the health center, used the virtual equipment, and the speech therapist was able to do their swallowing studies with the patient virtually, and we had a CAPS team member assisting them physically on the other end. So we were hoping that could be something that we could scale up as using our virtual care a bit more to ensure that patients have access to other clinicians and therapists.
And there's a last question in the Q&A.
Okay. Have you published? No, we haven't published yet. We just finished our findings, and we're hoping to publish in the coming year.
All right, Paula, thank you so much for your presentation. And thank you so much, everyone, for attending today. And indeed, feel free, if you have any questions, to email her, or you can find the PDF as well as the recording of this presentation on AGE and APPTA websites. Paula, I'll reach you on the other side. Thank you so much.